Good morning, everyone, and welcome to the Joint Assembly Committee and Senate Committee of the Subcommittee on Human Finances, not Finance, I'm sorry, Human Services. Madam Secretary, could you please call the roll?
Senator Canizaro. Senator Dondero Loop. Here. Senator Wynn. Here. Senator Severs-Gansert. Senator Titus. Here. Assemblywoman Anderson. Assemblywoman Dickman. Here. Assemblyman Hafen. Here. Assemblywoman Howdigi. Here. Assemblywoman Monroe Moreno. Here. Assemblyman Watts. Here. Assemblyman Yeager. Here. Chair Gorlow.
And I'm here. Thank you so much. Please mark those members missing present when they arrive. Welcome everyone in Carson. A little bit of housekeeping. Don't forget to turn off your electronic devices or silence them. If you wish to testify, please sign in at the door and also provide a business card to the committee secretary. For those joining online, please be sure to mute your microphone when you are not speaking to minimize any background noise. When testifying, please don't forget to turn on your microphone and clearly state and spell your name for the record. It does help our secretaries if you speak a little slower. And then also make sure you turn off the microphone every time you're done speaking. There should be 15 copies, I believe, maybe 10. You've got copies in the front, but there's also copies online for any of the meeting materials. As always, we expect courtesy and respect. We might not always agree with everyone, but we do want to be pleasant. And committee members will be using laptops and cell phones to communicate and look at handouts, so please do not take this as a sign of disrespect. We are going to start today with the hearings on 4 budget hearings. 7? I'm sorry, there's 7. There's more than I thought. Well, that's because I have a wrong agenda. It said February 9th. Whoops. That would be why. Thank you. Somebody didn't change my agenda. Sorry about that. Sorry. So we've got 7 of them. I believe Administrator Lisa Sarich is going to present. Please go ahead and start when you're ready.
Good morning, Lisa Sherrick, for the record, Administrator for the Division of Public and Behavioral Health, last name Sherych. Here with me today is Deputy Administrator Cody Finney, who's over the Bureau of Health, Wellness, and Prevention, Deputy Administrator Joe Millay, who's over our clinical services area, which is all of the state hospitals and rural clinics, and then Deputy Administrator Debbie Reynolds, who's over administrative services, fiscal IT, and HR. So if it's okay with the committee, I'm just going to jump right to slide 6, as the first 5 slides are items that have previously been provided in our pre-session, as well as our public health budget presentation a couple weeks back. So the first budget that we're going to talk about is 3161. This is Southern Nevada Adult Mental Health Services. That I'll probably just say SNAMS, if that's okay to shorten the length of that. SNAMS provides an array of services in Las Vegas, mental health services, which includes 2 psychiatric hospitals, Ross and Neal and Stein, and outpatient services that includes things such as mental health court, assisted outpatient treatment, residential services, counseling, medication clinic, etc. Additionally, the Stein Forensic Facility, along with Lakes Crossing Center, which we'll talk about that budget account near the end of the presentation, provides statutorily required treatment and evaluation services to mentally disordered criminal offenders for whom there is a doubt regarding their competency to proceed with adjudication. These services are provided both inpatient and outpatient, depending on whether the court determines the client may be a danger to self and or others. The facility also provides treatment services to clients who are determined not guilty by reason of insanity and individuals considered to be unrestorable and too dangerous and committed to the division long-term. In order to meet the demand for forensic services, we have a number of enhancements in this budget focused on increased bed capacity and staffing. M201 outlines our caseload enhancement, which requests 1 additional contract psychiatrist for medication clinic services waitlist caseload, and E380 requests to transition 12 intermittent temporary forensic specialist positions to permanent FTEs, along with the operating cost to maintain 13 additional forensic beds. I would like to note that 10 of those positions are currently filled, and we have candidates for the remaining 2 intermittent positions. Slide 8 is E381, which requests 21 forensic specialists for the Ross and Neal D-Pod, also known as Stein Annex D, to provide 24-hour direct care services to court-ordered forensic clients. And E382 requests 60 new psychiatric nurse positions for the same unit. E383 requests 1 forensic psychologist FTE and 1 contract forensic psychiatrist for Stein Forensic Services. And E673 requests a 2-grade increase for correctional sergeant, forensic specialist 3 and 4 FTE positions. Slide 10 provides an overview of our licensed and staffed civil and forensic beds at Ross and Neal Hospital. I thought this was important to include because it does get a little complicated when we're talking about units versus hospitals. And so while our Stein Forensic facility is 100% forensic units, this outlines better how Ross and Neal space is being used, and we do have some forensic units within Ross and Neal that are considered Stein Annex units. Next slide. This shows a map of Ross and Neal. This allows a better visual of the layout of the hospital. I hope you can read it. This was as good as we can get with the PDF version that we had, unfortunately. But as you can see, there's 5 units, and then there's a dining hall, an administrative space, and a gym. Slide 12 and 13 shows a picture of the D-Pod, which helps, again, to visualize the nursing station that splits the unit essentially into 2 pods. Each side has 10 bedrooms. And the nursing station is essentially a horseshoe or U shape. You can access both sides via the nursing station, but there isn't the ability to visually see both sides of the units outside of the, like even when you're in the nursing station or you're assigned to each separate side. So trying to provide that visual to better understand the makeup of those units without having a tour. And that concludes the major enhancements in this budget. Happy to answer any questions anyone might have.
Thank you very much. We do have a couple of questions. I believe Assemblywoman Howdegi would like to go first.
Thank you so much, Sharon. My question's on Decision Unit E380. It was the 12 temporary forensic specialist positions that were going to be converted to permanent if approved. You sort of answered it in your presentation. You mentioned that 10 of the 12 positions were filled. And so my question was going to be if those temporary specialists were going to be allowed to assume the full-time positions, but I'm guessing they were, since 10 of them are full, they're going to be considered for those full-time positions?
Lisa Sherrick, for the record, yes.
Okay, thank you. Thank you, Madam Chair.
Thank you. Next, we'll go to Assemblywoman Anderson.
Thank you, Chair, and loving the coordination. Wish I knew about green. My question has more to do with the state psychiatrist and the outsourcing, for lack of a better term, for one of those positions. So what are the challenges that are currently faced by the agency in hiring the state psychiatrist? And then also, what are the benefits to the division and the clients in the use of a contracted outside of our state? Because honestly, I'd rather have that they were state employees.
Good morning. Thank you for that question. For the record, Joe Malay, last name M-A-L-A-Y. And so state psychiatrists in our FTEs have been challenging to fill. We do have a rather large vacancy rate in those, so we do fill those gaps with our contract staff. What contract staff do in psychiatry, especially in other disciplines as well, they offer the flexibility of hours and, of course, additional pay. So those are the two biggest attractions for psychiatrists here. And so that's why the request for that, just knowing the challenge.
And Lisa Sherrick, if I may add, based on our vacancy rates, our psychiatrist positions run around 84%, whereas our psychologist positions were about 31%.
Thank you.
Thank you very much, and I'm sorry, I'm writing my own notes. 31% for psychologists, was that what you said?
Lisa Sherrick, for the record, yes, our licensed psychologist won positions.
Okay, thank you very much. And next, we have a question from Senator Wynn.
Thank you. Obviously, I think these beds are just long overdue and greatly needed. So this has to do with that D-pod construction. I know that you had said that you anticipated the construction would be done in June of this year, and that you need those 37 recommended positions are budgeted to start in October. I guess, when would those D-pods actually be opened, and when will we be ready to staff them? Like, when will it actually be functioning?
Joe Millay for the record. Thank you, through chair to you. The D-pod construction is estimated to be done at the end of June, as you had stated. Currently, we have moved those clients into the E-Annex, which it was a unit of Ross and Neal Hospital. So it's staffed there with those. The civil population is covering the staffing for those forensic population currently. So we continue to recruit all the time for those positions. We have done, we've used third-party recruiters that really help us a lot to get those positions. Even if they're contract, we can fill them sooner and then move them to state FTEs, and that's been pretty successful. We also can, we have a workforce development staff member who's really adapted new language that really brings in more forensic specialists in particular. So that's been a little bit more successful, and we've seen that as well. So we continue those efforts almost all the time.
I guess that kind of leads me to my second question, and kind of second and third question combined. I know that there's like an incredible backlog, or wait list, I guess, of people for those forensic beds. And it's 30, and I think we're running at around like 97, 98, I think that's what I've heard last, at least in Clark County alone. Is it a phased-in approach to like filling those beds and getting them up to capacity, or when it opens, are they opening and everything is full at that time?
Lisa Sherrick for the record. So I want to be candid that this 30-bed unit is not going to meet all of the demand. I think just the numbers speak for themselves. So yes, we are going to phase in, bring in, getting the staffing, and then of course as many individuals as possible from the jails to provide those restoration services. One of the things that do impact just statewide our forensic system, the ability to have that patient flow happen quicker, is the long-term committed individuals. We have 28, I believe. I'll get the formal number if I was wrong on that. But with numbers up in the high 20s for those long-term, they take up a bed for minimum 10 years. And we are not able to bring additional people into our hospital for those treatment services. So we lose like 3 to 4 people a year per bed. So that also is a very large contributor to our backlog. So I just wanted to mention that. We do also have the jail renovation project with the City of Las Vegas. That was the ARPA dollars back in October. And, you know, the goal is once that is up and running, that will bring on, so the dollars were to renovate 90 beds for forensics, but staffing was for 45 beds. So that was what was approved. That program or process to get that stood up is taking longer than anticipated. There's many factors that play a part as far as working with State Public Works Division, the programming piece to make sure that all the construction requirements will meet our licensing requirements. Understanding that we do have, you know, some ways to do compliance agreements, things like that. So those are taking a little bit longer. And additionally, I did just receive some information this week that there's some renovations that needs to occur in the other 2 units. So there's 4 units on this compound, 1 and 2, which we're going to occupy, and 5 and 6. 1 and 2, the city has individuals or inmates in that space, and they will need to be moved to the other 2 units. Based on a review, it appears there needs to be some construction that needs to occur for those other 2 spaces before we can move out at least one of the units to start our construction. So that will cause a little bit, well, it's going to cause a delay.
Thank you.
Thank you, and I believe we have a question from Speaker Yeager.
Thank you, Madam Chair. And I'm sorry, if I could go back just for a second to the psychiatrist issue. And so reading, I think you'd indicated it's $175 an hour for contract position, which obviously, based on the budget, that's going to cost more than being able to hire a state psychiatrist. So I had a couple of questions there. One, how is the $175 an hour rate set? And then 2, I'm assuming that a contract psychiatrist can do side work as well. And can you speak to that and whether, if we're to fill the position for state psychiatrists, are they allowed to do additional work outside of their state roles, or are they limited to the roles for the state? Because I obviously see that as an issue in finding somebody to work for the state if there are other opportunities being a contract.
Joe Millay for the record. Thank you for that question. Yeah, so the state psychiatric salaries, hourly salaries, as you mentioned, is set by both national standards and by our statewide psychiatric director, who always consistently looks at rates in order to kind of stay within as competitive as possible. So to the question, can a contract psychiatrist work other places? That's usually what happens when they come in part-time. We have a few full-time contract psychiatrists as well, but for the majority are part-time because they do have either private practices. We do have a system in our Human Resources Department that ensures there is no conflict, and where their secondary employment is, we're considered our primary, employment. So we do have that kind of a check and balance so that it's not competing. Thank you.
You're very welcome. Next, we have a question from Assemblywoman Monroe Moreno.
Thank you, Madam Chair, and good morning. My questions are on M201, the medication clinic caseload. Could you, and you may have covered it, and if you did, I apologize, discuss the factors contributing to the wait list for the clinic?
Yeah, Joe Millay for the record. The medication clinic in Southern Nevada for our wait list. We have a wait list currently of about 300. That's fairly consistent over the last couple of years. The medication clinic has a vacancy rate in psychiatry, and so while we have 10 psychiatrists throughout those SNAMS services in the medication clinic, we have 9 vacancies for state FTEs. We just had 2 candidates that are coming on board, so that leaves 7 vacancies in senior psychiatrist. We have 3.25 contract psychiatrists, but that leaves that 3.75 vacancies for those state psychiatry positions. And so that's why we can't reduce that wait list, is because of those vacancies.
Madam Chair, just a follow-up? Due to those vacancies, is that why you came up with the projected wait list? Is that how you determined what the projected wait list will be for the next biennium because of the vacancies that you currently have, or were there other factors that played into that?
Yeah, the wait list is actually calculated by those that are waiting for to get into appointments, and so that's how that's factored in. While we did have a reduction slightly in our medication actual clients currently that are being seen, that has actually gone up, and we expect, and on March 18th, I believe the Office of Analytics will have a new forecast for us for those that caseload projections, and we expect that to see an increase as well. And so that, with the help of the Office of Analytics and our actual data from historically, is how we come up with those numbers.
Thank you so much for the answers. Thank you, Madam Chair.
You're very welcome. Any other questions on this budget? Okay, seeing none, we'll move on to Budget 3162.
Lisa Sherrick for the record. So this is Northern Nevada Adult Mental Health Services, otherwise known as NAMS. They provide an array of mental health services that includes Deanie Townsend and outpatient services such as mental health clinic, assisted outpatient treatment, counseling, residential services, did I say medication clinic, etc. Slide 15 outlines our caseload enhancements for this budget. M202 requests to eliminate 5 psychiatric caseworker positions and associated costs based on caseload adjustments. M203 requests to eliminate 1 psychiatric nurse position and associated costs based on caseload adjustments. And as previously stated in the pre-session, we have been seeing an uptick in our outpatient services caseload, specifically for medication clinic, AOT, and mental health court. That includes service coordination. However, we will not have those official updates until later this month. I think Ms. Millay said March 18th. We're looking at getting those, but we don't have those today. Slide 16 is E900, which includes a transfer of PCN 377 from our budget account 3168 to NAMS. This position is currently assigned to NAMS, which monitors, evaluates program performance, and provides staff training. No duties are performed pertaining to budget account 3161, and by transferring this position, it will align budgetary authority accordingly. E901 transfers the Galletti Way Building 8 expenditures to Sierra Regional Center, budget account 3280 under ADSD. E903 requests to align funds of the Galletti Way Building 8A expenditures for NAMS to Northern Nevada Child and Adolescent Services under DCFS. And with that, happy to answer any questions on this budget account.
Thank you very much. I think our first question is Assemblyman Watts.
Thank you, Madam Chair. So I have some questions about the caseload projections for the outpatient coordination, mental health court, and outpatient assessment services. So it looks like there's been a pretty significant decrease in those projections. Can you explain why that is?
Jomali, for the record, thank you for that question. A couple things occurred that have caused those decreases. First of all, when ACA was expanded years ago, we did really work to get those individuals into other services so that once they were insured. So that was an effort that was pretty successful as well. COVID, of course, changed everything. It wasn't exactly the first year of COVID. It was like the following year after COVID in 21 when we really saw the decline of staffing. And that's really why we couldn't, a lot of retirements, changing of positions, and so that's where we saw the decrease. And we honestly, we just couldn't even bring in clients anymore because we did not have the staff, especially those in mental health counselors. And so now we've had, we've really increased our referrals, particularly from the medication clinic, because for service coordination and some of our other services, that's really kind of the cornerstone where people begin and then we refer out. So we're really looking at referring people now that come to our services. So that's increasing those caseloads as well. So we have seen an increase lately and an increase in staff. So.
Thank you for that. So I appreciate especially some of that context towards the end. So with these current caseload projections and the recommended position reductions related to that, and again, if you can kind of connect it to these other referrals that you're seeing, do you think that the agency will have sufficient resources to serve clients through the outpatient service coordination and mental health court programs?
Great question, Jomali, for the record. Additional staff, when we can see those numbers, would be great. We do really working hard. We're actually growing our programs with the diversion program, especially when we talked earlier about the forensic wait list. One of the continuum of care is getting those individuals into services and treatment earlier before they end up in the forensic mental health system. So if we can get them in, at least in our civil side or in community resources, that's really where our new focuses are starting to occur. So yes, we probably will need those positions, to be honest.
Thank you for that. And I think it would be helpful, at least for me and probably for members of the committee, to get some follow-up, because it sounds like staffing is the issue. And so it'd be helpful to understand a little bit more about those staffing struggles, and where we're losing folks or unable to attract folks because there's probably more competitive pay and benefits for some of those positions. I think that would be helpful for us to understand so that we can hopefully help get the staffing that's needed. Thank you, Madam Chair.
Will do. Thank you.
You're very welcome. Any other questions on this budget? Okay, seeing none, we'll move on to 3165, the crisis response.
Lisa Sherrick for the record. This slide provides an overview of this budget. The crisis response system is designed to assist individuals experiencing any type of behavioral health crisis and prevent such events from escalating. Too often the outcome is extreme, up to and including death by suicide. This is done by ensuring there is a system in place that provides an individual in crisis with someone to talk with, someone to respond, and somewhere to go when in crisis. This system will help keep individuals in crisis from ending up in the emergency department when they could be better served in a facility specifically designed for someone in their situation. The crisis response system will alleviate unnecessary deaths by suicide and allowing more Nevadans to live longer, happier lives. This account will fund the crisis call line, the care hub to coordinate the various aspects of the system, and portions of services at crisis stabilization units and designated mobile crisis teams. In the 2021 session, SB 390 created the Crisis Services Fund based on a fee assessed on telecommunications and mandated the creation of a crisis response system. These request the necessary personnel to support and manage the system. We have submitted a budget BDR to propose amending the language in NRS 433.708 that will allow us to collect the originally projected telecommunication fees revenue. We do anticipate starting to receive these fees in June of 2023. E225 requests to add 10 new FTEs to support crisis response and management of 988, which is a direct 3-digit line to trained National Suicide Prevention helpline counselors. And E227 requests to use crisis response telecommunication services fees to fund an existing clinical program planner 2 and to fund emergency crisis response activities, including the 988 Center. And with that, we're happy to answer any questions.
Thank you very much. Our first question comes from Speaker Yeager.
Thank you, Madam Chair. And I have a couple questions about the telecom fee surcharge. I think it looks like a temporary regulation was approved, and I think you just said that you anticipate, and maybe you can just confirm that you'll start actually receiving that revenue in June of this year, and then afterwards you'll do a more permanent regulation that'll come in front of the Legislative Commission.
Thank you. Thank you, Speaker Yeager, through you to the chair. Cody Finney, for the record, yes, that is the intention.
Okay. And then a follow-up, if I could, Madam Chair. Hopefully this isn't going to happen, but if there is a delay in collecting those telecom fees and for some reason like June just doesn't work the way we think it's going to work, how would that program be impacted, and is there any alternative funding source that could bridge the gap until whatever issues are there get fixed?
Thank you, Cody Finney, for the record. There is not an alternative funding source. We do have some pieces of startup funding through ARPA dollars and other time-limited grant dollars, but overall, the funding source for this program is that fee.
Thank you. And I have a quick question. Did you receive any feedback from the telecom companies on collecting the fee?
Cody Finney, for the record, Chair Gorlow, thank you. Yes, we did receive feedback from the telecom companies in the process of developing those regulations. They expressed, overall, in general, they expressed their support for this program and concept, and they provided feedback that we need to clarify those definitions to ensure that in their language, we're defining all of the phone lines, because it turns out there aren't very many landlines left. So if we only capture those, we're not getting everything we needed.
Thank you. And I do still have a landline. Yes, I do. My cell phone does not work all the time at home, but that's more info than everyone needs to know. So thank you for that. If the legislation was not passed, can you clarify what will happen at that point on the assessment of those fees?
Cody Finney, for the record, thank you, Chairwoman Gorlow. We believe what will happen at that point is we will collect a much lower than originally projected amount of money, and we'll have to scale back our activities and operations based on that.
Thank you very much. And I think our next question comes from Assemblywoman Anderson.
Please, sorry about that. Was trying to find some information out. How did the agency determine the need for a public information officer specific to the crisis response program? And do you believe that there would be any overlap with the current, the two existing public officers?
Cody Finney, for the record, thank you, Assemblywoman Anderson, to Chair Gorlow and all of you. The public information related to this program is particularly important. We really have to have, first, all of the pieces within the department and the government and the partners, this is incredibly complicated, have concrete and clear information. And then second, we need the public to know that this is there and that they can reach out to this. I do want to address, if you'll indulge me one tiny second, that we have heard from our communities that for feedback in the activities we're currently doing, the RFI we're about to put out, they're concerned about the focus on suicide in the documents that we've provided. And that is an artifact of how this developed from the federal level as being part of the suicide crisis line, and it is true that this is aimed at preventing suicide. But there's a long road before somebody gets to be suicidal where they might be in crisis and need help, and this is aimed at helping that with that road way before we get to the end of it. So I do want to emphasize that this is about crisis for people who have behavioral health issues or really any, anxiety, depression, the whole gamut. It's not just about somebody who's really ready to do something drastic. So thank you for that indulgence. The PIO, really critical that we have all that information. And so this position will focus specifically on this system and program to make sure that people have got the right information. So no, not a lot of overlap with those other programs. We have a behemoth division. There's lots of information that has to get out.
Thank you, and thank you for that other background as well, because one reason why it was taking me a little bit of time, I was trying to find some information as to whether or not the current PIOs are geared towards very specific populations, or if it's for the general public, or if it's also working with other agencies. I'm so sorry that I was not ready to go right away with that question.
Lisa Sherrick for the record. Yes, just due to the size of the division and the complexity of the programs, we have PIOs that are assigned to very specific areas. Our epidemiology section has a lot of information that needs to go out, and just that alone is essentially a full-time job. We have a clinical services division, so definitely there's enough work to go around. We get public records requests all the time for our division, media requests, technical bulletins go out to the community, the healthcare facilities. So all that plays a role in our PIO's responsibilities.
You're very welcome. Senator Titus?
Thank you, Madam Chair. So thank you for the presentation. I have a question. The 988 line is up and running, correct? So
Cody Fitty for the record, correct.
correct. So how has it worked for, one of my concerns all along with this 988 is that there's a lot of numbers floated around there for people in crisis. So we have a suicide hotline, a crisis hotline, we have our 211 numbers, and now we have a 911 number, and now we've rolled in this 988. And so I think that the PIO is going to be an integral part of this, and just wondering how will that merge? Because for me, it has to be that warm handoff. When somebody dials 988, you have to be able to give them somewhere to go. There has to be that warm handoff from that number. Have you been able to integrate that? Where are we in this process, as opposed to out on some island where they're dialing 988 and all these other numbers are floating? Then I have a follow-up to that.
Cody Finney for the record. Thank you, Senator Titus, to the chair. Thank you for that question. That is an excellent question. I get excited. We're not there yet. We have a wonderful team established working on this project of the crisis response system. So we've got the vision from the last session, and that Dr. Woodard worked with the community to develop. And now we've got a team in the Bureau working on the intricate details of how we do what you just described. So, for example, we were out meeting with law enforcement and other agencies in Southern Nevada this week, talking about that 911, 988 connection. So right now, it's very basic 988, which is also the other suicide crisis line, same call folks. They would just call 911 if somebody expressed that that's what they needed, or expressed information that suggested that's what they needed. In the future, this system, part of which is an information system, will help that communication be far more nuanced and intricate, and allow the dispatch centers to talk to each other. That is the vision. And we are working to get there. What we're working on right now is really solid information about how much that is going to cost, really solid information from those partners about how we're going to work with them to get it to work, because they're probably going to have to change some of their practices. We listed, I think, at least 9 information systems, and we know that technically it will be very challenging to have them all speaking to each other. So that is where we are in that process.
Follow up on that, Madam Chair? So thank you for that, because one of my concerns about hotlines is during the COVID crisis, we had a COVID hotline, and I dialed it just to see who I'd get. I got an answer machine. And so one of the things that you cannot have with mental health issues is an answer machine. Or when you dial the suicide hotline, they say, oh, no, you have to dial 988 now, and to ever hang up on somebody in a crisis. So is the technology there that when somebody dials, like the no wrong door, there's no wrong number, that there will be this integrated system where somebody still has this old number on the suicide crisis hotline? It's manned, though. It automatically goes to this other number, the 988 or whatever the number is, so that there's truly a live person answering that.
Thank you, Cody Finney, for the record. So that is one of the things, and I appreciate you redirecting me, back to that we are working into our contracts with the current call center that's doing it now, and it will be in any future contracts, that we are moving towards having a no wrong door approach. So if somebody has an old number, they will get there. If somebody's calling, needs 211 and they dial 988 by mistake, we will get them to the right place.
Great. Thank you for that. Thank you, Madam Chair, for the question.
You're very welcome, and I kind of want to expand on that too. Unfortunately, I've had to call 911 on a couple occasions, and as the senator mentioned, it wasn't necessarily an answering machine, but it's press 1 if you need the animal control, press 2 if you need 911, or 3. There was this menu of options, and I can imagine being hands-free on my car, calling 911 because you see an accident. Press 2 if you need, and that's not going to be possible. So I would agree looking into that a little bit further to make sure that it's a little bit easier for people to access the service that they need. And with that, did you? Go ahead, please.
Lisa Sherrick for the record. I just wanted to say I love your slogan, no wrong number, and I think we will have that discussion with our PIO, because that does make sense. And I have also had that experience when I've had to call in things driving, and you see potentially someone under the influence, and it's like, I need to get to the right people. So we definitely need to make sure that occurs. So thank you.
And thank you. And with that, we'll go to Senator Dondera Loop.
Thank you very much. And I am also a member of this committee that has a landline, and I have it for 2 reasons. One, to find my cell phone when I can't find it. And the second reason is because, as I've told my children, when you have an emergency and your cell phone is out of battery, you're in trouble. So I'm hanging on till the end. So do you think that those 10 positions are going to be sufficient to support that crisis response program?
Cody Finney for the record. Yes, we do believe those positions will be sufficient to support that program at the part that the state needs to do. Certainly there's lots of work happening in the community related to this, but these folks will be able to manage those contracts, oversee, monitor the performance indicators, and those sorts of pieces that are necessary.
The thing that always concerns me is, you could have a day where you have, a lot of crisis, right? And then you could have a day where you don't have any, fortunately. And so, we like that when we don't have those days, but when you have them, we want to make sure we have all hands on deck. And I think you answered this, back to the telecom fee surcharge, will that be enough to bring all those 10 positions on by October 2023? Thank you to all the landline people out there.
Cody Finney for the record. Yes, both projections provide enough to support those positions. I will add that we hope these folks won't be operating. It is not our plan for the state positions to be operating in crisis. The call center will receive the crisis calls and provides a little bit of insulation from the frontline piece for these folks who will be managing those contracts. But yes, the funding is available in both projections.
I appreciate that. And I also echo the senator's concern about so many numbers out there, because I think the needed numbers either need to be consolidated, or there needs to be that some kind of a slogan where it says, need help, here's your needed numbers, help them find those numbers, because some of those people, when they're in crisis, I mean, it's not like they can open up a phone book, right? So, or they may be even in a different city or state than they actually live in, and so one state may push it out as one thing, and another state another. So I appreciate all your hard work on this, and thank you very much.
Thank you. Next, we'll go to Senator Wynn.
Thank you, Chair. This kind of goes hand in hand with this. We're talking about this number and this no wrong number, no wrong door kind of attitude. And, I do see this as a very collaborative process, not only in connection with these crisis stabilization centers and how we're seeing them, kind of come into existence. I know in talking with the representatives, I know we work collaboratively in my district, along with my city councilman, Brian Knudsen, my county commissioners, Tick Segerblum and Justin Jones. And we've been working with Metro, trying to figure out a collaborative approach. And I know that you all have also been working with them. I'm thinking about some of these funds. In particular, I think there was about $30 million in ARPA funds that were allocated to these crisis stabilization centers. And a majority of them, actually, or a disproportionate number of them, went to, I believe, about $6 million went to Renown to help set up their crisis stabilization centers, and then we had about another $5 million that went to our rural communities in setting up those, and then the remainder went to, I think, 2 facilities down in southern Nevada, Desert Wind and Desert Parkway. But can you kind of explain some of the difficulty that we've had dealing with, what's the IMDs, is that what they're called? It's bringing me back to Ronald Reagan and some of the decisions that happened in the 80s that are now still affecting us now in the ability. Can you kind of describe to us some of the concerns we're having in setting up those crisis stabilization centers with those funds?
Thank you so much, Cody Finney, for the record. I'm going to take this opportunity to try to clarify a lot. There was a lot there.
I appreciate that.
So keep me on track. Okay, $30 million. So there are $30 million in ARPA funds. 10 million of that, and I can give you the work program numbers if that's helpful to you. 10 million of that was for surge crisis services in the community. So crisis services, but not the crisis stabilization centers that we're developing as part of the permanent response system. We have worked with...
Can I stop you right there? That 10 million, is it my understanding that it was meant as kind of like this in-between kind of bridge until those centers got up and running?
Cody Finney, for the record, that's correct. And we are continuing with that currently. I will acknowledge and be candid that there have been delays in getting some of those awards through our process. I will continue to brag on the wonderful units and bureau we've set up. We've hired almost entirely new staff and trained them, and I am just so proud of these folks. I really am optimistic that we're over the hump on some of these challenges. So the $10 million is that services piece. The $20 million which was in a separate work program, is for the tenant improvement and infrastructure I think of it as startup for these crisis response centers. We did have a competitive bidding process some time ago, and there was Desert Winds and Desert Parkway did express interest at that time. We have not provided them funding because there are additional pieces that I'm going to get to in a second about, from my perspective, there are additional pieces about how we can make this sustainable that have to fall into place, to your IMD point. Okay, so of the $20 million, $5 million is set aside for rural solutions. About $6 million has been obligated to Renown, and they have been the first runners, the first horse in this race, if it were that, and are making progress with us. It has been a very challenging road, but we're making progress now on setting up an adult crisis response or crisis stabilization center in northern Nevada with Renown. So that leaves the rest of the money, from my perspective, to address finding a solution in southern Nevada to prove this concept and get this going. We have been meeting with some of the partners you mentioned and others about, and Medicaid. Medicaid is integral to this piece, so we've been working closely and met with those partners you mentioned and Medicaid and us on Tuesday, and some of those providers, trying to hammer out the details of making sure that we don't bump up against the IMD exclusion. Medicaid has their 1115 waiver, and that has to fall into place in order for those services to be Medicaid reimbursable. And they are making progress down that road.
Can I stop you for a second? I think there's a lot of people that don't know what institutional mental disease. Can you kind of just briefly explain to the committee what that means?
Absolutely. Cody Finney for the record. Institute for Mental Disease is a term in the Social Security Act that excludes certain psychiatric care from being Medicaid reimbursable. And this was an artifact of deinstitutionalization and the federal government not wanting to take on, well, from my perspective, this is how I understand it, the federal government not wanting to take on those services, the cost of those services that had historically been provided in state psychiatric hospitals. That law still exists, and that means that Medicaid cannot pay for psychiatric services for adults but in a certain age group within an institute of mental disease, which is a psychiatric facility that is primarily psychiatric, is more than 15 beds. Did I hit all the... So if it's a...
And is that why Renown is able to, they were able to get this up sooner because they also treat other things and they have, the facility space to do this, and they also are treating mental diseases under this?
Thank you. Yes, Cody Finney for the record. So a large med-surg hospital is not primarily for the treatment of psychiatric disorders, and more than 50% of their patients, that's the third one that I was asking her about, more than 50% of their patients are not being admitted primarily for psychiatric purposes. I'm going to say that I'm trying very hard to quote federal law as I understand it, but we might want to get the actual words. So if you have, if a large-scale med-surg hospital is involved, then that gets us away from that IMD issue. Another method to get away from that IMD issue is an 1115 waiver that allows some of those services to be reimbursed. The state of Nevada is working on both of those tracks.
Thank you. And I know I asked you a lot of questions, so I appreciate those responses, and I can always follow up on offline too.
Please go ahead, Speaker Yeager.
Thank you so much, Madam Chair. And I just wanted to clarify, I thought we had heard a presentation earlier this session that waiver had been approved for the IMD exclusion. So could you just give an update on what, maybe I misheard the first time around?
Thank you, Speaker. No, you're entirely correct. Cody Finney for the record, and I appreciate the opportunity to clarify. CMS has approved their waiver. They are, my understanding, and I would certainly be happy to coordinate follow-up with my friends at Medicaid and Ms. Weeks. They are in the process of an implementation plan. So those waivers need to be approved, implemented, and funded, and then we can pay providers.
You're very welcome. You have provided a lot of information, and I'm the first to admit my page is filled with all the notes that will be very difficult to decipher later on when I'm looking them over. I hate asking you because I know you are super busy, but could you please provide us with maybe a one-pager that kind of roughly explains this, maybe some of the challenges that you've been facing in getting this set up in Clark County, and what we might be able to do to help so we can move this forward. Mental health is such a huge issue. I know we're all kind of preaching to the choir, but with Clark County being the biggest area of need, we'd really like to see that get set up.
Cody Finney for the record, I would be delighted to make that my top priority, and I'd really like to express our enormous gratitude to the councilman and the commissioner and the folks that have really been engaging with us and helping us get through some of these issues.
Thank you. Any other questions on this budget? Okay, seeing none, we will move forward to. Keeps turning off, I'm sorry. And it did it again. Okay, 3168, the Behavioral Health Administration.
Lisa Sherrick for the record. This slide is an overview of 3168. It supports the behavioral health budget accounts and also provides support to the Commission on Behavioral Health. This budget funds the Central Billing Unit and the Nevada Psychology Internship Consortium, otherwise known as Nevada PIC. E226 requests one new Administrative Services Officer for FTE to serve as the Chief Financial Officer for Behavioral Health. In July 2021, the division was experiencing unprecedented challenges due to COVID, including doubling our annual operating budget, which resulted in increased complexity and a significant increase in workload across the division. With this, we identified the need for two Chief Financial Officers, and we began using a vacant unclassified agency manager position for the behavioral health CFO. This request seeks approval for a new classified ASO4 to solidify the structure and ensure both CFO positions are equitably classified. E900 transfers one quality assurance FTE to NAMS. And E901 transfers two quality assurance specialists to the Bureau of Health, Wellness, and Prevention and Treatment, budget account 3170. That concludes this budget account. Happy to answer any questions.
Thank you very much. And our first question goes to Assemblyman Watts.
Thank you, Madam Chair. So on the creation of the ASO position, it sounds like this is kind of formalizing some changes that were already made, but what would be the impact to the behavioral health budgets if this position were not approved?
Thank you. Debbie Reynolds for the record. Trying to sit over here as close as I can. The impact if the ASO4 is not approved, we would continue to use the existing agency manager to serve as the chief financial officer, but it would create an ongoing disparity between the two positions. We have a classified ASO4 who serves as the chief financial officer for public health, and the chief financial officer for behavioral health is in this unclassified agency manager position. So, one can earn overtime and the other one cannot. It would ensure that there is comparable salary and compensation between the two positions.
Follow up, Madam Chair.
Please go ahead.
Thank you. So it sounds like, again, this is an issue of pay parity. It's something that we've seen in across other budgets, and that this is probably pretty important for retention of folks moving forward. Is that a fair assessment?
Debbie Reynolds, for the record, yes, that's accurate.
Thank you. Any other questions? Okay, seeing none, we will move forward to Budget 3170, Behavioral Health, Prevention and Treatment.
Lisa Sherrick for the record. Slide 23 provides an overview of budget account 3170. This account is accountable for developing community infrastructure, such as applying for eligible grants, grants management, statewide leadership, and strategic planning. This budget account also includes integrated mental health, substance abuse, and co-occurring disorders, including the development and submission of the biannual joint mental health substance abuse block grant. E901 transfers 2 quality assurance positions from 3168, and this transfer was outlined in that budget that we previously spoke about as a companion transfer. And that concludes this budget. Happy to answer any questions.
First, we'll go to Senator Nguyen, then I will have a question.
One second, Chair. I need to gather my notes, so maybe you can go on to the next person.
Yes, Assemblywoman Monroe Moreno.
Thank you. You didn't cover this in your presentation, but in our backup material, it appears that there was a $1.9 million that's going to be balanced forward for the assertive community treatment and forensic assertive community treatment programs, both in northern and southern Nevada. Could you just explain to us why that hasn't been utilized and why you need to balance forward the entire amount?
Cody Finney for the record. That funding is going to our counties. It's will be forwarded to start July 1st. We've got those awards ready to go. And it's our understanding that July 1st is the target start date. Those programs, it's my understanding that those programs are in place, and that this will be funding them in the future.
Follow-up? Yes.
So has there not been any work that's taken place in this area now that I guess I'll just say it, are we behind on paying anything now? Are folks doing the service in the community, working with people, and we are not paying them for the services that they're already providing? Or do we have people waiting to get the services until next year?
Thank you, Cody Finney, for the record. The Bureau and this budget in particular, if we have a wonderful pie chart in some of our presentations that shows the ongoing funding that's related to this is about 1/3, and the one-time funding, of which this is a part, is about 2/3 of the work that those folks are doing. So we've struggled to get a system set up. I am incredibly encouraged at this point that this team has set up a system, and for example, with request for reimbursement, our data right now is showing an improvement from more than 60 days to pay a request to an average of 17 days. So we've been working very hard to set up a system. So are we behind in paying people? We are definitely making progress in the right direction. It's my understanding that in this particular case for the Act in Fact, that work is happening in those communities, and that this funding will be for the fiscal year starting July 1st. And that and that they're using other funding at this point. That is my understanding as I sit here today. Are there people who are waiting for us to pay them in general from this group? We've also reduced our backlog of awards. For example, there was 27 awards in one of the units, and they were down to 11 as of last Friday. So we're processing those documents so that we can get this money out in general as quickly as possible and making good progress in improving those metrics.
Please go ahead.
So I'm going to ask a question that's probably going to light my fiscal staff's hair on fire. So IFC, we approved the funding back in October. And community organizations that you guys are working with, for that funding, for us to approve it, those programs were vetted, and we know that they're good programs. Would it be easier in the future if funding was just put in your budget so that when there wouldn't have to be a reimbursement, just directly pay those organizations for it? Just a question, and hopefully my fiscal staff doesn't kill me.
Lisa Sherrick, for the record, I think we would love direct funding when there's times that could be done versus coming through us.
If I may have, in my efforts to share some of the progress we made, conflated two things as well, that we are doing sub-awards as well. So certainly we could get into the details of that, but I don't want to light any of our fiscal staff's hair on fire either.
I won't get us both in trouble today. Thank you, Madam Chair.
Thank you. And I'm going to go to Senator Nguyen. She has a follow-up on this topic, and then I promise, Senator Severs-Ganser, you will be next.
Well, since Assemblywoman Monroe Moreno opened the door, I feel like it's open. I can go in now. I've just heard from, we have a system where we are relying so heavily on our nonprofit partners and our private interest partners to take on the role of so many of these programs that that partnership is so important. And I'm glad to hear that there's progress, but I've heard horror stories about nonprofits not being able to pay their bills, having to lay off people, being evicted from their properties because they are months and months and months in arrears of not being paid for services that they completed, or they completed services that they were initially approved for, only to be told, hey, you've completed all these services, but they're not covered. So I'm curious on I'm less optimistic on the 2 months going down to 17 days. Is there a way for us to see how those things are paid out and where those delays are?
Cody Finney, for the record, certainly we can provide the data that we're collecting. My perception is that those metrics that I'm speaking to are what was needed in order for us to avoid those absolutely unacceptable situations that you're talking about. We do work, I can think of a particular partner that we work very hard with to make sure that we knew that they were small and needed help, and worked very hard, and also with the university, to make sure that they were not going to suffer some of those pieces. We've been working with them right up and until yesterday, and we'll continue to do so. But my belief is that those metrics I'm talking about are what we really have to be monitoring, and what some of these staff will be doing in order to be in front and have these awards going out in a timely way, and the payments going out in a timely way.
And if I may, Lisa Sherrick, for the record. So we have had some discussions within our division as well about just looking at us as a whole. And, essentially there was a Lean 6 project that was done several years ago about streamlining all the money that comes through in contracts, sub-awards, et cetera. But the fact of the matter is we haven't had a chance to really circle back to that. I think it served its purpose back then, and the things that were implemented, and definitely we need to make sure we're accountable for all the dollars that come through us and being able to meet audits from the federal government on grants, et cetera. But with us doubling our budget, I think we need to look at, is there something else we need to consider to be able to make these dollars flow through quicker and more timely? I have also had some conversations with community partners. Personally, we are looking to coordinate a town hall with providers as well. So we're all like talking about what makes sense, what are some gaps. We might think a gap is not a gap, or vice versa, or they think it's a gap, we don't, but we need to have those really candid conversations as a whole versus like individual conversations, as well as making sure providers know that if there is a concern, there's multiple people involved in all these discussions, that they can and should reach out to myself, to the bureau chief, to Cody Finney, so we can make sure that we can address these things as quick as we can, because we agree this shouldn't occur. This was never our intent, and we certainly don't want to impact the community in these negative ways to where people could lose their jobs, are losing their jobs, people having to live on credit cards. So that is not something that we see as acceptable, and we're doing everything that we can to try to remedy that.
Thank you.
Thank you. And as promised, Senator Severs-Gansert is next.
Thank you, Madam Chair. So I wanted to talk about the opioid dollars that are coming down, and I know these are for certain block grants, and I don't know whether your division is going to be covering that, as well. But just the idea that we have maybe $288 million. I guess the state's portion is less than that, so let's say 50% of that coming down, and if your team is going to be addressing how those funds are used, because they're in line, kind of in line. I know there's a state plan that's being developed, but they're sort of in line with the types of uses that these dollars are for.
Thank you, Cody Finney, for the record. So I need to ask for clarification when we say opioid dollars. This budget account and this bureau work on the state opioid response grant that comes through the federal government. If we're talking about settlement dollars, that is actually administratively someplace else, and I won't be able to have.
So thank you. So I am talking about the settlement dollars, so I'll hold off on that. Thank you.
Thank you.
Thank you. But that kind of leads me to a question, because going through our backup documents, I noticed that there's going to be an opioid exposure test in the newborn screening process. So I was a little confused why it was put there, as that's meant for endocrine and metabolic disorders. So could you elaborate a little bit on that, and also the sort of community treatment and how those programs are working together?
So, Cody Finney, for the record, in relation to the opioid screening, that is a voluntary screening for umbilical cord that will be done through the state public health lab. We've worked with them, and really, as of yesterday, had a breakthrough about the logistics of how that will work, and have a sub-award ready to go to them very shortly. So your question was, why was it put there? This is the bureau that does substance abuse prevention and wellness, and that activity was identified as something that would help with data and information and intervention for women who may have exposure while they're pregnant, and infants who've been exposed while in utero. So it came to this bureau. But our partnership will be with the state public health lab, where they do those screenings. So from the customer perspective, it will appear seamless.
Thank you. That does help, because I was imagining it was part of the heel prick that we do. So it will be like a separate consent form, because I know with the newborn screening, it's an opt-out versus an opt-in. So this would be an opt-in versus an opt-out.
Cody Finney, for the record, that is my understanding, and I'll be happy to confirm that.
Thank you very much. Are there any other questions on this budget? Okay, seeing none, thank you very much. We will go on to Budget 3645, the Lakes Crossing Center.
Lisa Sherrick for the record. Lakes Crossing Center provides the same services as described during the SNAMS enhancements for Stein, so I won't reiterate that unless you would like me to. The only difference about Lakes Crossing is it is considered our maximum security forensic hospital. E673 requests a 2-grade increase for senior correctional officers, forensic specialists 3s and 4s. And happy to answer any questions the committee may have.
Thank you very much. Committee, are there any questions? Okay, seeing none, we will move on to Budget 3648, the rural clinics.
Slide 27 provides an overview of rural clinics. Specifically, these clinics provide outpatient behavioral health services to both adults and children with mental illness in rural counties outside of Washoe and Clark. And we only have one decision unit, E228, which requests additional office space at rural clinics in Fernley, Yerington, and Panaca. Happy to answer. Did I miss one? Maybe I missed one. Oh, sorry, E350, I apologize. Rural Clinics is requesting budgetary approval to increase funding for mental health courts to provide rental assistance for additional 4 people in our mental health court program at a cost of $1,000 per month per person per fiscal year. Happy to answer any questions.
Thank you very much, and we have a question from Speaker Yeager. I'm sorry? Assemblywoman Hadigi.
Thank you, Madam Chair. And I was curious about the COVID dollars for this budget. Are you guys having trouble spending any of the COVID recovery funds that were approved for the rural mobile crisis response teams?
Joe Millay for the record, I apologize. For the rural response mobile crisis team, or just so I'm clear, are you talking about the adults or the children? Because pardon me? Oh, no, I'm sorry. No, the ARPA dollars, we are not having any difficulties with those ARPA dollar spendings. So in the rules, we do work with our counties to run those programs as well.
Thank you, Madam Chair.
You're very welcome, and I believe Senator Dondera-Loop has a question, but on the lakes budget, I believe? Sorry
Yes,
about
can
that.
I back up just a minute? Did you, I know in our information it says Lakes Crossing is only for the criminally, so is that changed over the years? Do I remember that it wasn't always that way?
Lisa Sherrick for the record. No, it was always established as that. It was built in the 70s, I think 1976. So my understanding, it's always been forensic. And that term is still the DSM term as well, if you're wondering, because it's a little.
Just to make sure I have it in my mind from back when I did a tour or something, where is that located? That facility is located? I feel like I see it on a corner somewhere.
Yeah, Joe Millay for the record, great question. It's in Sparks on Galletti Way. And so I think one thing that when you mentioned the chain, has it always been a forensic facility? There's an annex that was part of Deanie Townsend facility that was civil, and we converted it to additional forensic beds.
Okay. It's always good to know that the memory still works. Thank you very much.
And if I
Yes.
may, Lisa Sherrick for the record, in Las Vegas, Stein Forensic Facility was originally civil. So maybe that might be a little bit of the confusion. So that was built in 1976 as well for civil services, and then we converted it to forensic beds only in, it closed, and then we converted it to forensic, I believe in 2015-ish.
Okay, thank you for that information, and sorry to back up. Thank you, Madam Chair.
You're very welcome. We'll go to Assemblyman Hafen next.
Thank you, Madam Chair, and thank you all for being here today and presenting. I was looking at the last budget item, 3648, and it talks about the transfer contracts for the behavioral health. One of the things that's come up in my conversations with some of the rural communities and when I was sitting on the Southern Nevada Behavioral Health Board is that a lot of these rural communities have one ambulance for the entire community, Tonopah, Caliente, et cetera. And when there's a behavioral health crisis and they have to be transported, that ambulance is now removed from the community. And so now, heaven forbid, one of us gets in an accident outside of Tonopah, there's no ambulance to transport us now, or anybody else that happens to be traveling. I know you mentioned ARPA dollars. I don't see it in the budget for additional ambulances, but is that something that's being considered for use for some of the ARPA dollars? I know it's both behavioral health and public safety, but I just wanted to ask the question while you're here. Thank you.
Jemily, for the record, no, and we understand the resources are limited in the rules. What we try and do through our call lines in particular is really reduce any kind of crisis there by de-escalating and providing family resources so that we don't take ambulances out of service. We do have an 88% diversion rate from hospitalizations because we understand keeping those ambulances free to transport for those that absolutely need it. But it really has not been in our conversation. It's kind of out of our purview for ambulance services for those ARPA dollars, but it's a great suggestion. Thank you.
Thank you. Thank you, Madam Chair.
Very welcome. And next, we do have a question from Speaker Yeager.
Thank you so much, Madam Chair. Just had a question on 3648, the E350. It mentions additional funding for mental health court rental assistance. Are we doing mental health courts in rural areas? I thought we just had them in Clark and Washoe, so wanted to just ask for some clarification on what exactly that money was for.
And Jemily, for the record, a mental health court is provided in Carson City.
And thank you for the question. Committee, are there any other questions? Okay, seeing none, thank you so very much. I had that as my last budget.
Lisa Sherrick, for the record, just the last slide is a
Oh.
request for back language, which is
go
extremely
ahead.
important for our hospital system.
Please go ahead then.
Oh, just we're requesting the ability to transfer general fund appropriations between SNAMS, NAMS, and Lakes Crossing with the approval of IFC committee upon recommendation of the governor.
Thank you again. Did anyone have any questions on the back language? Okay, seeing none. All right, now we're done. Thank you so very much. And with that, our next agenda item is public comment. As a reminder, everyone will receive 2 minutes for public comment. For those that are in Carson, please come up to the table and we will start here. Oh, and don't forget to push the button and state and spell your name for the record. Thank you.
Good morning, Madam Chair and members of the committee. My name is Sarah Adler. I'm with Silver State Government Relations, and today I am going to applaud you and give you some feedback from 3 clients: Vitality Unlimited, New Frontier, they're rural treatment and CCBHCs, and First Med, which is an FQHC in Las Vegas. So all of them could not appreciate more your questions about streamlining the reimbursement process. Vitality at one point this year had an $800,000 outstanding to portions of DHCFP and or DPBH. And I think what we are fortunate in Nevada is some very long-time providers who have financial statements who can handle that, but that prevents staff increases or salary increases for retention, and it prevents staff increases for creating greater services. So one idea they have is if we are a 20-year provider to the state, maybe we would get a gold star and front load some funding that then reimbursements come again. They would also like to say, however, that there's a key problem in the process. They submit cost reports, which they are willing to do, to be audited for appropriate uses of funds. And those cost reports are involved in establishing rate payments. It can take months and months for the cost report to be approved, to find out they're reducing your rate, that you've already been paying your staff for providing services at that rate. So there are some very significant timing and rate establishment concerns. Finally, ACT is happening big time in Elko, in Carson City through Vitality, in Fallon with New Frontier. Vitality also provides ACT in Reno. And it's very important for retaining people in the community rather than in Ross and Neal. Thank you.
Thank you. Please go ahead when you're ready.
Hello, Elise Monroy Marsala with Bells and Case Government Affairs. I'm here today on behalf of NAMI, Nevada. NAMI just wants to make sure that their comments on the record about their support of the 988 system. NAMI partners in Nevada have been supporting for the last couple of years a warm line that has been very successful. So this 988 work to give people an opportunity for a place to call just builds on that. So they just want to make sure they are on the record in support of 988. Thank you.
Good morning, Barry Cole, Barrycole. Just want to do the math real fast. $364,000 a year. If you're a contract psychiatrist, earn $175 an hour, and you work 2,080 hours a year. What's considered a full-time equivalent. If you did state benefits, you'd probably roll back about a third because the benefits package will be about a third. That sounds like a great number, except let me point out, last year in Flagstaff, Arizona, I made $275 an hour and $345 for overtime with car, travel, and lodging provided. The graduates at UNR already know that telepsych jobs will pay $380,000 a year, and you get to sit at home to do your job. And the state of California is now offering to recruit our graduates from Reno at a starting base salary of $279 with a lot of benefits, and once they become board eligible, they go up to about $345,000 a year with the same benefits. So we're keeping 70% of the graduates in Las Vegas. We're keeping 25% of the graduates in Reno from the two departments of psychiatry operated by the state. We don't yet have data on the Southern Hills program. I think they're only in their third year, so we'll know in about another year what their retention rates are. In 2020, I just want to remind you of something. The Nevada Psychiatric Association, for which I'm a member, started Curbside Nevada in 3 weeks. We were providing live, warm conversations for any healthcare professional. I don't care where you worked in Nevada. If you were having a bad hair day, call us. We answered the phone 18 hours a day for 4 months until the crisis sort of stabilized. I gave advice about what meds to use for their patients, and I also provided psychiatric support for people who were really decompensating just from what was going on. So there's a lot going on we need to think about. There's no easy solution. It's going to come down to money. It always does. And I had these same discussions back in the 90s with your predecessors when I sat at this table to testify and tried to explain the budget for SNAMs and NAMs in the whole state, as well as what we were doing in the rural. It hasn't really changed that much, just new faces. Thanks.
Thank you. Any other public comment in Carson City? Okay, seeing none, we'll go to Las Vegas. Don't see anybody in Las Vegas. Broadcasting, is there anybody on the telephone?
To give public comment, please press star 9 on your phone to take your place in the queue.
Good morning. Can you hear me?
Yes, we can hear you.
Thank you. My name is Jamie Ross, Jamieross, speaking on behalf of the Nevada Statewide Coalition Partnership, representing prevention coalitions in Nevada. I would like to tell you how important funding for primary prevention is. We often use the upstream-downstream analogy, If people keep falling off a cliff and drowning in a stream, we absolutely must save them. But if the only money we spend is for ambulances and hospitals, and we do not look upstream to figure out why, where, and how they are falling in, we will never truly solve the problem. This is what primary prevention does: build supports to keep our communities safe. Prevention is public health. We follow the public health model. We ensure that we are involving all sectors of the community, including those who have been historically disadvantaged, in decisions affecting them and ensuring that everyone is served. I'm here to discuss a line item in the 3170 budget, meth prevention funds. From this year to next, there looks to be a $114,000 per year budget cut that will affect directly prevention programming in schools, community centers, parenting classes, and this would mean cutting sometimes only the only prevention programs that someone may see. I'm here not only to speak about what will happen if we lose this funding, but to your points earlier, how important timely funding is. Multiple agencies receiving funds within 3170 are getting contracts 3 months to 6 months into a year, requiring agencies to float staff costs, all fixed costs, and then oftentimes attempting to do a year's worth of work in 6 to 9 months, or delaying reimbursement requests by many months. SACTA and DPBH has worked closely with all of these community agencies to solve these issues, but unfortunately the problem persists. The problem seems to be larger than just this agency, and often we are told it is in the contracts unit. I'm happy to discuss further with you additional context and on the burden this would place on our prevention agencies and connect you with affected treatment and behavioral health agencies. Thank you.
Thank you very much for your comments. Broadcasting, is there another caller?
Chair, the line is open and working, but there are no callers at this time.
Okay, thank you very much. With that, we will close public comment. Committee members, any comments? Okay, seeing none, I believe we are not meeting tomorrow, but the Subcommittee on General Government will be. So feel free to tune into them. And with that, we